Good evening. Welcome attendees to another webinar in the Emerging Techniques and Significant Contributors webinars from the Royal College of Surgeons, FDS. My name is Jack Glander. I'm a member of board and a consultant maxillofacial head and neck cancer surgeon and professor of surgery at Brighton. I have the delight in introducing an old academic lecturer that I had the privilege of being taught by many years ago at Bristol. Professor Jonathan Sandy was a professor of orthodontics and the inaugural Dean of the Faculty of Health Sciences at Bristol University. The Faculty of Health Science comprises of 3 schools, both medicine, dentistry and veterinary sciences, and he completed the role in July 31st of 2019 and is now retired. He's been the previous head of the Oral and Dental Services Sciences Department for 7 years before taking on the faculty leadership role of the entire college. His dental training was in London at King's College Hospital, then the London Hospital, and then the Eastman. He was awarded the MRC Training Fellowship, and after his PhD was funded the very prestigious MRC grant, which funded his postdoctoral scientific work at the Biochemistry Department at the University of Cambridge. Appointed at Bristol University as a senior lecturer in '91, promoted to reader in '97, and very quickly after that awarded a personal chair in '99. His main research interests are in cleft lip and palate and the delivery of cleft care with healthcare workers. In fact, he's made a significant contribution to this idea of centralisation. He's co-authored 3 books, more than 250 peer-reviewed publications, and his total grant funding exceeds 5 million. So with great pleasure and privilege, I'd like to introduce Professor Jonathan Sandy, who will be talking about centralisation of specialist services, a way forward. Thank you, Jonathan.
Thanks very much, Jag, and thank you for attendees. I'm now retired, but when I reflect over the last 40 years of being a dentist and all the other bits and pieces, what's the impact? Well, this probably is the most impactful work that I got involved in. And it's just interesting to talk about centralisation and specialisations and how effective they are. So I'm going to tell a little bit about centralisation, the pitfalls, the advantages, and then I will talk about cleft, and I'll talk about craniofacial services, and then pose questions to you as to what other things you might like to see centralized in your own areas, and you may be surprised at what could be centralized. It's a good start. I can change my slides. Okay, fine. So what are the advantages of centralizing a service? Well, ideally, you concentrate your expertise and your resources, you improve your outcomes, and you improve the quality and efficiency of care, and that will give you proficiency in delivering those services. You'll also develop multidisciplinary teams that have significant meaning, because centralization of specialist services doesn't work unless you've really got good teams and good collaborations between all those people caring for an individual. Potentially there are cost savings. People will argue about this, and I don't think our methodologies for working out economic evaluation have yet been defined or indeed refined so that we can prove this. In theory, you will, of course, have fewer staff compared to a centralized service. What are the disadvantages of centralizing services? Well, there's a cost, and that cost may not be to the organization, but it may be to the patients, particularly with regard to travel. And then is there fair access to those specialist services? You need to be careful. You run the risk of centralizing and de-skilling regional units, and I'll show you some examples of where that de-skilling of your regional units may actually impact on your centralization. And I think this is a fair point, that if you're going to centralize a service, you've really got to carry out a proper evaluation. And you've got to look at what is the impact of decentralized care and be sure that you're actually making the right decision. I think it's also worth reflecting that in low and middle income countries, they may require very different models. If you are living somewhere where it takes you 4 or 5 days of walking to get to a centralized unit, then if you have common diseases like tuberculosis or HIV, a centralized model may not work because those people will need to travel for so long, they may not be able to access the care they need, which could be delivered more effectively if it was local. So where do we know that centralization has worked? I'm going to talk about stroke, some of the cancers, congestive heart failure and coronary artery bypass grafts. I'm going to talk about the pediatric intensive care units that have been centralized and about joint replacements by orthopedic surgeons and what the impact of that centralization has been. So if you look at acute stroke services in London, this is a really interesting centralization model because it wasn't totally dependent just on creating these height 8 hyperacute stroke units, which were created in 2010. It was also in parallel, the ambulance service and the paramedics were brought in and were shown to be highly effective by delivering clot busting drugs as soon as they were able to and before they got into those acute stroke units. But it did mean that politically this was difficult. The acute stroke services were discontinued in 22 hospitals, but as a marker of how effective that centralization was, inevitably there were still some patients being treated in trusts without those hyperacute units. And for those 15% of patients, 6 out of 7 indicators worsened, and that included death within 7 and 30 days. So highly effective decision to centralize these services, and if you didn't or you were treated outside centralized service, your outcomes were shown to be poor. Childhood cancers, this is some work from a 6-center study in European countries. Interestingly, the data was delivered from a national registry, and national registries play a big part in how you decide where care should be delivered. But what they found from these 6 centers was that the survival for children treated in high volume hospitals, especially for brain and blood tumors, there was a big increase in survival. They used their registries to prove that, and they also recognized that this centralization needs ongoing evaluation. So those two things, registries and that ongoing evaluation, are themes that come through in all centralization of specialist services. You've got to do it, otherwise you're not going to take everybody with you. And certainly in the UK, hematological malignancies in children, particularly the leukemias, were centralized, and exactly the same thing happened. The outcomes got better and the treatment got better for those children. It's been looked at in prostate cancer. This is work that actually came out of the clinical effectiveness unit in the college, where they looked at prostate cancer and asked the question, how did centralization actually change the modalities? Well, it was quite interesting because the radical surgery or high dose radiotherapy were more likely in units with these facilities. So that's a kind of no-brainer really. But if you had treatment, it was actually going to be decided what the facilities were rather than having everything there. So centralization can potentially have a negative impact on treatment offered. Coronary artery bypass grafts, which you just look at coronary artery bypass graft surgery, it's unequivocal that high volume hospitals with high volume surgeons result in lower mortality rates and lower complication rates. And the same is true for orthopedic surgeons, and the orthopedic fraternity have a fantastic national registry. They have learnt so much about all of their knee replacements and hip replacements, what type of joints work best. Is it metal on metal or other various materials? But they can also work out where they are treating patients as to what are the complication rates, what about readmissions and reoperation, how long is the stay in hospital, and what's the mortality risk. And in high volume hospitals, those are all shown to be low. And again, the National Registry is really powerful tool, not only in delivering treatment, but also in the research that they're able to undertake. And this is a kind of classic of pediatric surgical procedures. And when pediatric surgery is looked at, and that does of course include cleft, it's always charged with emotion because everybody wants to have their own unit on the same level as the post box on their street, but we can't do that where you have got these difficult and rare diseases. So if you look at pediatric surgical procedures, biliary atresia is the one to look at. And this was centralized in 1999, based again on national outcomes analysis. And what they found was that when they looked at that national outcomes, there were disparities which were based on case volume. So the problems with a low volume operator were that they were getting poor results. So they designated 3 centers, King's College, Birmingham and Leeds, and they said that is where all these operations are going to be carried out, including liver transplantation. The drivers for this weren't just looking at outcomes. The drivers were also there coming from parent organizations, and the media were well aware that there were differences around survival rates around the country. And they centralized in those designated services, and the outcome data improved significantly. The pediatric intensive care units, I saw this firsthand in the Southwest region. So these were centralized in the UK in '97, and the model was that they would send out a retrieval team to transport children that were critically ill. And the local teams obviously would not have been happy about losing their high dependency units. And what they had to do was get over this attitude was, oh, the retrieval team has turned up or is coming, and therefore this child will be taken to the center. Those regional units actually had a lot to do with maintaining the child's life until the retrieval teams were there, and they needed to be part of that centralization. That centralization is still being evaluated and needs ongoing evaluation. And the recognition in this particular model that the local teams were needed to be included as part of the service. So I've painted quite a rosy picture of centralization and all the advantages, but there are also disadvantages. And having been appointed in Bristol in 1991, the Bristol heart scandal blew up. I can tell you now, it was a very difficult time for all the consultants in the trust. These are the 2 surgeons, Wishart and Dasmana, and John Roylance was the chief executive. They were all medically qualified. This obviously had General Medical Council consequences. Steve Bolson, who's the young guy in the bottom right-hand part of this slide, was the anaesthetist who was desperately unhappy that children were coming to Bristol and were not surviving. He was brave. I hate to say it, but he'd been drummed out of Bristol. He now lives and works in Australia. Steve, at one point, I know, rang the Department of Health, pleading with them to stop an operation that was going to happen the next day, because he said the child will die. And he was absolutely right, the child died. It was a horrible time. The consultant body was actually very divided, some supporting the surgeons and others supporting Bolson for being brave enough to stand up to this. Steve Bolson's actually written a book about this, the Bristol heart scandal, and he doesn't hold anything back. Harrowing for the parents, but that is why you have clinical governance. And from all of that has come clinical governance, where we do recognize all the things that go towards providing safe care for patients and the best care for patients. And audit is a big part of that. Most of us hated audit when it first came out, but slowly we've grown to love it and embrace it within clinical governance. But these were the things that were coming out with the press. At least 95 families of children who died or suffered brain damage, currently involved in discussions over legal moves against the trust. Depending on the severity, these claims could be potentially worth more than $1 million or more each. So not a nice time. It's what happens when centralisation goes wrong. And children coming for this surgery were coming from all through the southwest region and indeed Wales. So there are risks and unknowns in centralisation. You've really got to monitor any centralisation that you do and evaluate it. We don't know yet what the economic evaluations are because we don't really have great methods and reporting of this aspect. And we need to think of wider issues in healthcare when you are looking at costs and outcomes, and that includes the patients. Do not make decisions at a whim. The evidence has really got to be there. It may be transferred from other centralized services, but it needs to be robust. And you need to develop reliable outcome measures if you are going to convince anybody that you are going to centralize a service. So I'm going to talk about cleft lip and palate. When this edition of Private Eye came out, there was a whole pile of stuff in there from MD, known as Phil Hammond, and he picked up on all the Bristol Heart stuff. Phil Hammond was one of the first people to start really bringing this to the attention of the media. But in that same edition where they were going on about the Bristol Heart scandal, he'd also picked up that the Clinical Standards Advisory Group was carrying out a study to try and centralize services. And I don't know where he got his information from, but at the start of that study, the last thing we needed was something like this, because he said the scandal around cleft lip and palate is compounded by petty professional jealousy between some plastic surgeons and maxillofacial surgeons, only against the patient's interest. And because the Department of Health weren't doing anything, MD suggested you might like to look at the following hospitals: Exeter, Birmingham, Stoke, Wexham Park, Falkirk, Wrexham, Shotley Bridge. I didn't even know where Shotley Bridge was. Carlisle and the Royal Surrey. It was incredible where this list came from. And we were immediately accused of leaking a whole load of information to the press before we'd actually completed the CSAC report. But it was quite interesting, the power of the media in this situation. So what about cleft lip and palate? Well, it's a common craniofacial anomaly, the most common craniofacial anomaly. Somewhere in the world, a child's being born with a cleft every 3 minutes. And it's not just a matter of repairing the cleft. They face a lifetime of functional, social, and aesthetic challenges. There's some emerging evidence they may have educational difficulties, but I'm going to talk a bit more about that. But there's no doubt they need multidisciplinary or interdisciplinary care. For many years, for this speech, the oral health, particularly oral health, the hearing and the well-being. And when I was appointed in '91 to Bristol, these two patients walked in. So the first slide of the unrepaired, or the first picture of the unrepaired alveolus, was a chap who was an incredibly successful businessman, but wanted to know if we could do anything for him, because my orthodontic service had just opened up. So people were being referred. And he'd been patted on the back at the age of 13 and told there was nothing more that could be done for him, and he would be like this for the rest of his life, but he would be okay. And somehow he managed to survive all of that. Patients on the two slides on the left, that was quite harrowing, and clearly the system had given up on the patient, and the patient had given up on themselves. And at that time, there were still people using these Latham plates, which are nailed into a child's head, into the palate, and they're still used in some parts of the world, but particularly developing countries like America, but actually have not been used in this country for many years. So this was kind of UK cleft care 30 odd years ago. And it changed really through that Clinical Standards Advisory Group study, but the two people who drove that change, in my view, in terms of research in this country, Bill Shaw and Gunvar Sem, and I don't know how they find time to sleep, because the studies and collaborations they've set up all over the world are quite extraordinary. But the 6-center European study they set up, which was based in the UK, Oslo in Norway, Denmark, Stockholm in Sweden, and Amsterdam, as well as Manchester and Great Ormond Street. I think that changed the way that we finally decided we had to deal with this. But the study they set up, there were consecutive cleft lip and palate cases. They looked at lots of outcomes, and they found that the outcomes seemed to be better in centralised services. And the two UK centres, which if you look at the graph above are centres C and D, seem to have the worst results. Now the data in that chart is from Mike Mars's Goslon Index, where they look at the dental arch relationships, and both centres C and D had a big pile of patients who all fell into the worst groups 4 and 5. And if you're below that cutoff point of 4 and 5, you probably need an osteotomy to have a normal facial profile. Compare that with Centre B, which is Copenhagen. Majority of the patients are well above the red line, and their bad results are sort of order of magnitude smaller than Manchester and Great Ormond Street. The other thing that they noted about the services in the UK was that they had many surgeons operating on these children. In Manchester, there were 12, and they came from 4 different specialties. So that was, I think, a big driver in why we needed to look at the service in the UK. This is a graphic illustration of what the differences were. So the condition is a child born with bilateral cleft lip and palate. The one on the left was treated in the UK, and that is an orthodontic and restorative nightmare to try and do anything just with the dentition. But by contrast, the slide on the right is a bilateral cleft as well, treated in Oslo, and that is a fantastic opportunity to provide someone with an occlusion that will last them for their life. That represents the stark differences between the best centres in Europe and the worst. The Cleft Lip and Palate Audit Subcommittee in the Royal College of Surgeons, headed up by Brendan Devlin, also provided information and showed that across the UK there were mainly low volume surgeons accounting for about 10 cases a year. They weren't very good at keeping records, and there wasn't a lot of multidisciplinary care. There was, as Private Eye alluded to, a bit of a turf war going on between specialties. And the Standing Dental Advisory Committee was a committee which at that time could talk directly to government. But with all of this evidence, it was inevitable, although there's a lot of hard work by a lot of people in order to get it to the front table, that we might start to look at how cleft was being delivered across the UK. And the Clinical Standards Advisory Group study was essentially an audit with 2 study groups. There were 57 collection centres that we had to collect data from. We collected data only for children born with unilateral cleft lip and palate, and over a 2-year period. They were either 5-year-olds or 12-year-olds. It was a cross-sectional study, so the 5-year-olds and 12-year-olds could show us different things. We identified in a 2-year period that these children were born, how many there were. We hoped to collect 250. We got pretty close to the target, considering the miles that had to be traveled to collect this information. Alison Williams and David Bien were the registrars who did most of this work. And the 5-year-olds and 12-year-olds showed us different things about cleft care. So the 5-year-olds, we could look at the surgery that they'd had for the lip, the palate, and pharyngoplasty. 12-year-olds presented an opportunity to look at alveolar bone grafting. And then other outcomes that were common, the speech, the hearing, the psychology, dental caries and orthodontics. And the 12-year-old group, we could also look at their lateral cephalometric radiographs to see what the skeletal profile was. Just look at alveolar bone graft. In Oslo, it was introduced very soon after a couple of case reports came out. There weren't even trials of any sort. They introduced it into their package of care with a 97% success rate for that operation, whereas in the UK as a whole, from the CSAG study, there were only 58% or less than 60% of these were successful. 42% were seriously deficient or had failed. And if you looked at dental relationships in the 5-year-olds and the 12-year-olds in this national audit, you'll see that in both groups, the 5-year-olds, we assessed dental relationships with a 5-year-old index, which was developed with Mike Mars from his Goslon index. And you'll see that in both groups, about 40% needed to have osteotomies, or indicated that they would need to have osteotomies later in life if they were going to achieve a normal profile. So clearly the osteotomy rate was of concern, but the fact that it was the same in the 6-center European study and the same in the national study was really starting to tell us something about the way that cleft children were being dealt with in the UK. And the Clinical Standards Advisory Group study came out in 1998. John Murray, who was a professor of pediatric dentistry in Newcastle, was the chair. And we started to look at what the problems were. Well, there were 74 surgeons who were operating on these children, and the majority were doing less than one child with unilateral cleft lip and palate a year, which probably equates to about 5 cleft children a year. It was very, very low. And then when we looked at speech outcomes, this was quite harrowing. 20% of the 5-year-olds had speech that was unintelligible to a stranger. And you can just imagine your first day at school, whereas a 5-year-old, you've got a funny face, you may have difficulty with hearing, you will look different, you'll have a scar, and you won't be able to speak properly. So you're going to have a tough time, and there is no doubt that the CSAG findings were really quite harrowing. But did this centralisation work from the CSAG study? Well, we looked 15 years later, a study led by Andy Ness, who's a professor in public health medicine, in fact, working in the dental school, and he led the second run of the original CSAG study in a study called UK. So now it's supposedly a little bit easier to collect data. There were only 16 operating sites as opposed to 57, and these were organized into 11 managed clinical networks. We only looked at 5-year-olds because the 5-year-olds would have been the only ones treated in the centralized service, not the 12-year-olds. We managed to get very similar numbers of recruitment to the study. Again, we took children born over a 2-year period and had almost identical figures in the numbers that we captured. We looked at the volume by surgeon, and this had changed dramatically. There were only 18 surgeons identified. All of them, bar 3, were operating on more than 40 cleft children a year, and the highest volume we saw was 120. And there was about an 80% response rate from the surgeons to this study. And I might add that the 3 surgeons who had a volume that was less than 40 were surgeons who were in training or one who'd returned from an illness. So did it work? Well, we looked at the 5-year-old index that's graphically shown there, that the best results in the 1s and the 2s. You can probably make a plan with that, but when you're in the 5s, it's quite difficult to see how you can get a good orthognathic result, and you're likely to need orthognathic surgery to correct. But big change, nearly a 50% improvement. The 1s and 2s, i.e. the best results, went up significantly, and the very worst results, the group 5, came down significantly, and we recognized that there was a big drop in those really bad results. So very pleased to see that. And speech was the other big change, about a 50% improvement in our speech outcomes, and now some of the best speech outcomes in Europe. And again, all these speech areas, which I won't attempt to explain, big changes and big improvements with the original CSAG results shown in red and the UK results shown in green. So pre-centralisation is in red, post-centralisation is green. You can see the big changes that have happened. So the conclusion from all that cleft work, and that was, for me anyway, was over a long period. Cleft care centralised in the UK, treatment has changed because actually what we found was the surgeons, and this has been corroborated from work with the clinical effectiveness unit, the surgeons are all doing very, very similar treatments now. They're not different camps of different philosophies of operating and timing. They are all operating in a very similar way. There will be differences, of course. The outcomes have improved overall significantly, but there is still room for improvement, particularly around dental caries. And I think it's really high time that we had a very effective plan and campaign in order to improve dental caries in these children, which is bad in cleft children anyway from day one. So we need to do more work around that, and also more work around improving the hearing of these children. So how do you evaluate this economically? I think the first thing is that you've got to recognize you need to define what is meant by high volume. Because you can have a high volume, but that does not necessarily measure quality, and that cannot be more graphically illustrated than with the Bristol heart scan. Many of the studies that lead to centralisation are not fantastic studies. They're not randomised, and most of them are retrospective, including the Clinical Standards Advisory Group study into cleft lip and palate, and indeed other areas of CSAG activity, which included leukemias and schizophrenia. So you've got to be cautious how those things are implemented, because you may not be doing the right thing. And if you use bad studies, do it cautiously, because you might be making the wrong decision. But economically, if you look at this is work Thomas Stutzman did from both CSAG and Cleft Care UK. Before centralisation, this is shown in yellow rather than the dark red. Before centralisation, this was the cumulative incidence of secondary surgery for lip, palate, nose, and then any requirement for secondary surgery. And after centralisation, which is shown in sort of dark chocolatey brown, you can see it's dropped dramatically. Now, if you are doing less secondary surgery, it is costing you less money, that is for sure. And if you then take outcomes, so how many patients had outcomes that were defined as ideal outcomes in 3 main areas. Before centralisation, only 7% of patients were getting ideal outcomes in 3 areas that were deemed critical. But after centralisation, this went up to 38%. So a 3.3-fold increase in the chance of achieving a good clinical outcome without secondary surgery. Economically, that has got to be absolutely viable. And from centralisation, you may see unintended benefits. So the national registry, when we completed the CSAG study, I was invited to the Department of Health to talk about a national registry. And at the time in CSAG, the way that data was collected around children born with cleft was Mark Hammond, who was an orthodontist in Birmingham, used to sit with his laptop on Sunday afternoons while he was watching the football and feed in the children born with cleft that week in the UK. The Department of Health were aghast. They immediately gave us £70,000, which was a lot of money, to start working up how we could create a centralised national registry. And it had a slightly checkered history. It went to Birmingham for a while and then came under the Clinical Effectiveness Unit. But this is the power of the registry. It's been running 20 years. We've had more than 22,000 registrations since then. And if you compare that to the Swedish registers and the Danish registers, which have been running much, much longer, Sweden 40 years, and the Danish registry over 50 years. only about, or less than 8,000 in each of those countries. The information that's yielded from those databases is really significant. Some of the research that comes out of those registers is really, really useful. And we can do so much more in the UK because we have got this peculiar issue of volume. We've got a population of 68 million. We have a lot of cleft births. We can use this registry to educate ourselves, but also what happens around the world and what are the best practices around the world. The other benefit of centralization is around research, because you can suddenly start doing more meaningful research if you've got fewer centers to collect data from. And any mum who has a child with a cleft will usually ask 3 questions at some point. What caused this? What's the best treatment for my baby? And what's going to happen to that baby in life? How will they grow up? And what friends and families will they develop? And those are important questions. And I said earlier that one of the things that we were concerned about was the educational attainment of these children. Information coming out which seemed to indicate that these children weren't doing so well at school. It's fine to say that, but actually what are the reasons? And you need to be able to do research that finds out the reasons. So is it their cognitive development isn't working, the brain size or function, and there's some sort of quite loose information out there that says their brains are different? Is it that genetically their genes for learning, hearing, speech are different? It is, after all, a neural crest anomaly. Is it that their speech, the hearing, the surgical outcomes are lending them towards bullying and teasing and social exclusion? Is it that teachers are biased, because we've got evidence that teachers are biased against children born with cleft? Or is it their speech, this intractable 20% of children who just have their education hugely affected by this? Well, we answered that question a little bit later, but we also, in this centralized model, started to think about research. And in 2005, we set up a workshop in Bristol. George Davies-Smith, who's the epidemiologist of his generation in the world, came to it and talked very openly about what the research opportunities were. And at the end of a 2-day workshop, we'd established what the clinical questions were. And George said, you've also got the opportunity to develop a gene-backed cohort study. Easily said, George, but we didn't have any money at that time. But by 2013, we had some fantastic funding from a charity called the Healing Foundation, which is now the Scar-Free Foundation. And we started that cohort study. It's been running 8 years. We've collected data from 11 centers, 16 surgical sites. We had a target of 9,800 individuals. If we hadn't had COVID, we definitely would have made that by now. We're confident we will be able to continue the study. We want to continue as long as possible. But the information we've collected includes the blood from the baby, questionnaire data, saliva samples, discarded tissue at operation, surgical information, and cord blood. So we've got nearly 150 mums who've been diagnosed antenatally and have then donated their cord blood to the Cleft Collective. And that cord blood is really important, because if you want to look at environmental exposures, cord blood is the thing to look at, because the children will not have had external environmental exposures at that point. So for epigenetic studies, it's a really important resource. And the other thing that we have started to look at is this issue of cleft and education. And we asked the question, this was work carried out by Christina Dardani, and she won the adult Huddart Medal for this at the Craniofacial Society. And she used publicly available data and then techniques that we will be applying to Cleft Collective data. She looked at non-syndromic cleft lip and palate children. She looked at 12 SNPs in these children, and then she set up some controlled studies where they looked at educational attainment and intelligence. And she used a technique called Mendelian randomization and linkage disequilibrium. And she came to the conclusion that there is no causal effect of cleft on either education or IQ, which is fantastic because it means these children haven't got something inherently wrong with them. They've probably got issues that we can remediate, like their hearing, their speech, attitudes of teachers, and put in additional resource at a time when these children most need it. I think of relevance to this whole argument around centralisation is what happened in the craniofacial centres. So this was a very different approach where the centres were designated, and there were 5 of them in Liverpool, Birmingham, Great Ormond Street, Oxford, and Glasgow. And the designation, in my view, is obvious. This is a very rare condition. But actually, without the kind of process we went through for CSAG, they don't have common outcome measures. They tend not to collaborate in the same way that cleft teams do. They don't have a regular common audit. And they've also got to fight off this leakage of their service, because if you're in Shotley Bridge and you've got a surgeon who thinks he can deal with a single fused suture, they may not want to send that child to Glasgow to have it done. So this leakage of service is a potential problem. But their genetic research is absolutely outstanding. It's been led by Andrew Wilkie in Oxford. And if you just take his work on Appert's, he's done this on lots of different craniosynostoses. It's a rare condition, but he identified that the mutation was in the fibroblast growth factor receptor gene, FGFR2. And what happens is that the receptor loses its specificity, and it allows any old growth factor, fibroblast growth factor, to bind. And this gives the receptor a gain of function, and that receptor is firing off constantly, and much more bone forms and in the wrong places, and the sutures get fused. These are the sort of conditions that Andrew was seeing all the time as a clinical geneticist in Oxford, where there was this designation. And he said, okay, we can do more around the genetics once we start collecting information from parents as well as the probands. So the craniosynostosis and perforations are not caused by raised intracranial pressure. That is a bone anomaly. And when Andrew looked at all of this, he said, oh, this is what happens. This is the root. So it's a sporadic stochastic event. You tend not to get many people reproducing with Appert's. This is where the mutation is in the receptor, from the C to G mutation in the receptor. It's male specific, so the paternal allele is the problem. And then he identified that there were mutations sitting in sperm islands within the testes, and you could actually map where these mutation islands were, the sperm islands, and you were dead unlucky if one of these mutated sperm actually fertilized the ovum. But what they did note was that the mutations increased with paternal age. So outstanding, absolutely international research in their genetics, but not so good with the other sort of common things like a national registry and the data collection we have for cleft, the outcome measures that have been developed, that cleft has got clinical excellence networks for the nursing, for orthodontists, for surgeons, and they carry out regular audits so they compare how they're all doing. And they also engage in very big international studies. The one is Bill Shaw's timing of palatal surgery, and the craniofacial centre's going to struggle to match that because they don't have that same they don't have the same volume of patients, and they're more complicated. But their genetic research, as I said, we're trying to catch up in cleft, but we've got miles to go. Andrew Wilkie is not an FRS for nothing. Good outcome research, Eurocleft, ScanCleft, TOPS, the CSAG, CC UK, we've shown that for cleft. And I kind of get the impression that cleft is trying to get more towards the strength of the genetic research that craniofacial has got, and craniofacial coming back to try and define their outcomes. So what do you need if you're going to centralize a service? Do you need rarity? Possibly not. I think you've shown from orthopedic surgeons you'll get enough data from registration if you're running a national registry. And I know Tom Dudding is doing some work in Bristol looking at the possibility of doing this for dental implants. And you could understand how you would understand which dental implants work best if you actually had a registry where all this information was collected. Ideally, try and get patient and media support if they can see what the issue is. And key is getting professional support. You need evidence, you need outcome measures that you can actually use. Ideally get commissioners on board, but be very clear about what it is, what benefit you think this centralisation is going to deliver. And you may already have information because the research may have driven your outcome measures. Your outcome measures have got to be robust, reliable and valid. And you may find that there's previous research that has identified issues that you need to think about if you're going to centralise, and even from the audit data, if it's available, may actually help you identify the issues. You also need energy and conviction, drive and commitment. You need to be very clear about what you're trying to achieve and have a very thick skin. I got asked questions on a Friday afternoon, very late, from the government, because there was a bill in the House the following week, or there were questions in the House the following week, and they wanted to determine what the elephant traps were. And they finished by saying, "Don't worry, we're not going to leave you to hang out to dry." And I had a horrible weekend because I never figured out what that meant. And you also need a lot of luck and some really good colleagues to work with, which I think I have been blessed with. So happy to take any questions. Thank you.
Brilliant. Thank you, Jonathan. That was a wonderful presentation and actually very relevant to maxillofacial surgery, particularly head neck surgery. We're certainly seeing a big move towards centralisation with, it just comes down to volume. You're doing 100 flaps a year. Your outcomes and your measures will be better. 96% is a survival rate for free flaps. Anything that deviates from that will raise a few alarm bells, or certainly a few eyebrows. But also the training opportunities that one can offer in a regionalised, centralised service will be significantly better than somebody who's not able to do that kind of volume. And ultimately, it will come down to maintaining that high level of standards through training the next generation. I do have a few questions. I've actually had one from Dr. Danielle Khalid, who's posed a couple of questions. Are you saying Oslo had good results with centralisation? I'm assuming that was the Oslo impact because of centralisation.
Yes, absolutely. And their centralisation is seismic. Their children are born in the Arctic Circle, and the government will actually fly them down to a centre in Oslo. And that is the equivalent of flying from London to Rome. That's what centralisation is really effective at, if a government is prepared to back that travel.
Sure. And he then went on to ask, you said the jealousy factor between plastic surgeons and oral maxillofacial surgeons, but this thing is due to overlapping of specialties. Just need more clarification. I'll let you speak first, and I can give you my perspectives on this as well in head and neck.
Okay, good question. Good question. At the time, there really was a bit of a turf war between maxillofacial surgeons and plastic surgeons, and they both felt this was their territory. But actually, there were other specialties that were involved. So pediatric surgeons were doing this, general surgeons were doing this, ENT surgeons were doing this, and it just was not clear who it was. And actually, what Jag has said about training, there's a wonderful piece in the bulletin, the electronic RCS bulletin that's just arrived by Matt Fell, which talks about what the advantages of centralisation are for training. And the TIG fellows, the training fellows in Cleft, come from two parent specialties, maxillofacial surgeons or plastic surgeons. It's much, much better than it was. And I think there are much clearer lines as to who should be doing what.
Super, thank you. And said from my perspective, there were old historical kind of boundaries, gentlemen's agreements between the various specialties. You know, we've got ENT, max fats, and plastics all involved in head and neck. But the units that are stronger and the units that have grown are the ones that collaborate and will pull down those barriers and actually find the best in people. We've just appointed a plastic surgeon to join our head and neck team, which is maxillofacial surgeons. And that shows a real strength of character, but it shows a willingness to want to engage and get the best from each other. I've got a couple more questions. I'm assuming that actually upon centralisation of cleft services, that would have been agreed by government bodies, that you would have had buy-in by parents, certainly patients and maybe professionals, most of them. But was there any kind of political agenda behind the scenes that could have influenced the outcomes for centralisation?
Yeah, the immediate fallout when the CSAG came out, there were letters being written in all sorts of journals. It was messy and it was unnecessary. We had some surgeons who used the media and used parents to say that the whole study was flawed. You know, it was retrospective, it wasn't randomized, that questionable analysis, and maybe the interpretation of the data wasn't all it should be. But actually, these questions were being asked by people who'd been on the CSAG committee. And I thought, well, you can't do that because you signed up to this. You signed up the report. John Murray made sure that report was unanimous by the committee, and they all signed up to it. But nevertheless, they didn't like the outcomes, some of them, and they did use the media. I was threatened with legal action on more than one occasion. And it was, you know, it was deeply unpleasant. I think in the end, the Clapper, who were fantastic and part of CSAG, did an awful lot to bringing the parents all on board because their main concern was access. And interestingly, in the CC UK, we found access hadn't changed. They were having fewer appointments with the centralised service, and therefore they had less travel to do. So there was a lot of noise, and you'll get it with any change in service, you always do.
I mean, I can think of an immediate kind of disadvantage to any centralisation, certainly here in Kent, Surrey, Sussex, where patients have to travel quite a significant distance. And when you've got treatment that requires so many visits and so much follow-up, how do you manage around these issues of patients having to travel further with centralisation?
Yeah, but the model that developed was that where you have these repeat visits for speech, for orthodontics, it was better to have a centralized decision treatment plan and then actually have treatment delivered in conjunction with the center by the local units. So a lot of that repeat travel, you know, if you're traveling 180 miles to Bristol from Truro in order to get an archwire change for your orthodontics, that is not actually a very good outcome. But if the local orthodontists are all bought into treatment planning and understand what is needed from them to help the center and the patient, then that cuts out an awful lot. And the example I gave there of pediatric intensive care unit is exactly that, where you have a hub, but you have lots of spokes, and the spokes need to connect to the hub. Otherwise, the wheel falls off.
And I guess that's probably been a little bit facilitated by the impact that the pandemic has had on how we manage face-to-face consultations with more remote digital adaptation of consultations, which means that again it's another strategy to get around the inconvenience that a long travel poses parents of young children. I've got a comment here for you, Jonathan. A great presentation, Jonathan. It brings back many memories. Thank you. And that's Rosalind McMillan.
Oh, Ross, yeah.
Then I've got one final question for you. What would you change around the centralised cleft model, if anything?
Yeah, the actual model, I wouldn't change anything. I think the evaluation, the constant evaluation, we need to be very careful about how that pans out, mainly because there is a mood, and this happens with centralisation, where people in the centres think, oh, it's all okay, we don't need to do this because we know we're good at it. the constant re-evaluation. We should have a Cleft Care UK study done every 15 years, just to make sure that we really are continuing to improve all the time. And I think Crane could play a much bigger part in that. So the one thing I would want to change is probably to see Crane better supported, but better utilised as well, with more access for everybody to understand fully what is going on in Crane. It's the power of a national registry, and I don't think we've quite got there. It's become a little bit too isolated. We will get there, but that is the one thing I would want to be changing: the constant evaluation. Make sure that is really rigorous and external, and then the national registry.
Super, Jonathan. You obviously at the end of your career, and the prestigious one that it was. Any words, perhaps of wisdom, or any real kind of nuggets of advice you can give to somebody who is perhaps at the beginning of their career as an academic orthodontist who has aspirations for a professorial position? Any words of wisdom that you can give us?
I'll tell you something that was said to me very early in my career, and it stood me in good stead in the main. That if you were ever asked to do something, do not have a first reaction of, no, I'm too busy, my diary's too full, I need more headspace. Just say yes. Don't worry if you can't do it. You'll just be known as a person who says yes, and will get things done. And you get trust that way. I was told that when I was a house surgeon. Just say yes. And I used to do it all the time, particularly the maxillofacial surgeons who were always asking the impossible. I just say, yes, Mr. Foreman, that won't be a problem. And I think that works really well. Just be that person that people want to go to because you get things done. And the benefits from that are not massive overload of work. You'll just be seen as someone who wants to actually succeed.
Super, thank you. That's really useful words of wisdom. I've got just a couple more housekeeping things to deal with. We have the next webinar on the 15th of June, chaired by Professor Helen Rodd, with panelists Dr. Lucy Musson, Laura Timms, and Professor Joey Marsham. And the topic of conversation will be embedding meaningful patient and public involvement in health research. And that's such an important part of any grant application, is your PPI. So that's going to be hosted next month. I want to thank Jonathan, and hopefully we will be able to invite him to the college when we're opening our doors again. The new revamp is progressing very nicely, and then we can start to have some face-to-face meetings again going forward. So have a good evening, Jonathan. Thank you very much for a wonderful presentation. It was my pleasure to host you, and good evening to the attendees. Bye-bye.
Thanks very much.